Welcome to Orthodontics in Interview. It's my absolute pleasure, Claudia, to have you here on Orthodontics in Interview podcast.
The pleasure is all mine, Farooq.
So we're here, of course, in Dusseldorf at the 15th benefit meeting. You were talking today. It was really exciting to have you here. And I wanted to steal you for this afternoon to have a discussion about your topic, about airways and orthodontics. This topic has been controversial and remains controversial. In fact, it may have even increased in its controversy. So I'm really excited to have you here so we can explore these topics about where you stand, where the science stands, and how that actually affects our pediatric population. We've had two AAO papers now, white papers. Most recent ones came out in 2026 at this particular topic, and still a massive grey area. Before I get into today's topic, Claudia, a bit about yourself. So you are an orthodontist specialist from Austria. You had your dental studies that you carried out over in Germany. You're a registered specialist from 2023. Now, what I liked about reading about your bio is that you're passionate about engaging with colleagues, which means you like to have differences of opinions and you like to have those conversations, which is great. Your interests are quite a lot, actually. Clear aligners, use of skeletal expansion, but also airway management as part of a holistic look at patients, which we'll get into for today's conversation. You're a key opinion leader for Ormco Spark Aligners. You've got 16,000 followers on Instagram, which is way more than I do. You have my envy, and you like to create digital education, which is really interesting and great to watch. Today's topic, airways. Irish proverb, a good laugh and a good night's sleep is the best cure from the doctors. This is back from the 18th century. Now, we've gone from having a quantity of sleep as an ideal now, looking at the quality of sleep. And this disorder of obstructive airway, obstructive sleep apnea and sleep disordered breathing is a relatively new field within medicine. If I can give a brief summary of the topic, it affects maybe 1 to 10% of the adult population, less in pediatrics, about 1 to 5%. But those numbers are questioned. And there's the International Classification of Sleep Disorders. Obstructive sleep apnea is there, but there's other classifications. Central sleep apnea, but also sleep-related hyperventilation. In terms of the effects of this apnea, essentially there's less oxygen going into the patient. Oxygen desaturation takes place, and that's been explored in terms of apnea-hypopnea index. But also we're seeing now there's sleep fragmentation that takes place, a disturbed sleep. The quality is affected. The effects are pretty significant. We're talking about mood changes, depression. For children, it's hyperactivity takes place, but significant medical problems. Diabetes, increased blood pressure, obesity, potential cancer, cardiovascular problems with children. These are really significant things that take place for what is a poor night's sleep. Why it's controversial? Different theories as to why this takes place. Different causes for patients. Collapse of the airway, most obviously. Arousal thresholds, new ideas. Altered neuromuscular responses and ventilatory control. So all these things make quite a confusing picture as to what this actually is. Starting off, Claudia, how did you get into this field?
Farooq, first of all, I want to say thank you for doing this podcast. I can tell you do your homework. Just by doing this little introduction, I think this is a great summary. You're doing a great service to patients as well as colleagues. So just wanted to say thank you for that.
Thank you. I don't hear it enough, but thank you.
Also, the way you do it is very interactive. People like listening to you. I enjoy listening to you.
Oh.
And you're very considerate. Like the way you ask the questions, I can tell you put a lot of time in preparing this. And I just want to thank you for that, because people might not see it when they just watch for 30 minutes or whatever, how much work that goes into it. I am able to see a glimpse of it, and I just want to say that I'm grateful.
Thank you so much. That's really meaningful. Thank you. I really appreciate it. How did you get into this topic?
My patients, actually. I had no idea about breathing airway whatsoever, but then my patients would tell me they stopped snoring. And I thought, this is weird. I mean, we did skeletal expansion because there was a crossbite. Now they tell me they stop snoring. I'm very into, optimizing my performance. I know how important a good night's sleep is for me. And I thought, if there's a chance I can contribute to a good night's sleep for my patient, I want to know all about it. And then I was looking for answers. How does it explain that we do expansion and the patient doesn't snore anymore? And then I looked into the literature and I found Dr. Stanley Liu, who was researching at Stanford together with Audrey Yoon, who was on your podcast. And they explained how the expansion of the upper jaw can reduce the severity of sleep apnea. So this is where I thought, somebody found an answer. There is a link. I want to learn all about it. And right now, most of my patients seek me because they want to improve their nasal breathing. They want to improve their breathing during sleep. So it was my patients who brought me into it. And I'm really glad that I am where I am today because it adds so much more value to my daily work. It's the stories of each patient, of the mothers telling me that their children are sleeping silently now, that the issues of bedwetting are gone. And this is so rewarding. And it really made me even more passionate about orthodontics than I have been before.
Really interesting. And we're going to touch on those topics, especially getting into bedwetting. I want to see where that stands and how we understand those components taking place. In terms of when these patients come in, how are you as an orthodontist who is experienced within this field, how are you diagnosing these patients as they come in?
So first of all, I don't diagnose sleep apnea. I don't diagnose nothing that's related to sleep. But I ask them, can you breathe well through your nose? Do you breathe through your nose at night or through your mouth? So a better question to ask is, do you wake up with a dry mouth? And if somebody's really breathing through the mouth at night, they will wake up with a sore throat and a dry mouth. They will know that. And I ask them if they snore. So this is my 3-question pre-screening. If they're positive on any of those questions, I go into more detail, more diagnosis.
Great. In terms of looking at patients' facial types, when we had Audrey Yoon on this podcast back in 2022, she was really excited about potentially being able to phenotype these patients. Can we screen for them depending on their craniofacial phenotype? There's been a number of studies that have gone into it. Most recent last year, Ting Ting Zhao, 2025, looked at 8,000 patients, found very little difference in pediatric patients who had obstructive sleep apnea and patients who didn't. No difference in the A and B. There was a 2-degree difference in SN to maxillary plane and mandibular plane, essentially showing that there doesn't seem to be this adenoid facies, this long face, skeletal too, doesn't seem to be related to the condition as it currently stands. Is that your experience with it as well? Do you still tend to see certain craniofacial types presenting more with this condition?
It's not as straightforward as we would like to have it. It's not that every class 2 patient is snoring. It's not that every transverse deficient maxilla cannot breathe well through the nose. The adenoid faces, I think this has been described in Ear, Nose, Throat Doctor, and he recognized that if the adenoids are huge, the patient cannot breathe through the nose, and this alters facial development. And I think it's really hard to deny this. If somebody's breathing through the mouth day and night, this will have an impact on facial development. And he even describes a crossbite. So that's really funny because in the Dome course that I'm hosting with Dr. Stanley Liu, he actually looked up this initial paper. It was written with the hand, illustrations. It was from 18 something like that. And this ENT, ear, nose, throat doctor, he described a crossbite. He described this high arched narrow palates.
I suppose the question is that if the patient has a high arched narrow palate, but we're seeing them in the population without obstructive sleep apnea, there's still something else going on behind that process, which means that there isn't a direct relationship between actually, if we do agree with the premise that actually it's the obstruction that's resulted in the patient's craniofacial type, but actually if the patient doesn't have obstructive sleep apnea and they still develop the same craniofacial type, is that not enough to say that actually this is not causality, this is just a weak association?
I'm not quite sure how to answer this question. I can, first of all, I want to say most of our patients don't have obstructive sleep apnea. Obstructive sleep apnea is on the very end of sleep disordered breathing. We will have a lot of patients who are mouth breathers in our practice, not necessarily mouth breathers during the day, but rather mouth breathing during the night. So meaning that for some reason, it's easier for them to breathe through the mouth at night. You cannot do a diagnosis of breathing, which is something, a very dynamic process, by looking at a lateral ceph. This is not possible because you're completely also missing the transverse dimension. So it wouldn't make sense to, I think it's more important to look at the ceph or at phenotypes, maybe for orthodontic purposes, but not necessarily to make any conclusions about breathing.
Yeah, that's great. And I think what Audrey was hoping for is that there would be an association to make it easier to identify these patients, because that's also the real difficulty. How do you diagnose patients? You're absolutely right. On the end of this sleep disorder breathing, obstructive sleep apnea seems to have pretty reliable processes. But what about the patients on the way there or somewhere in between? CBCTs gets quoted a lot in this space in terms of literature looking at obstructive sleep apnea. Do you take CBCTs for these patients? Do you see changes? Do you plan around those changes?
I take CBCTs to plan the position of the mini implants, especially in adults. I don't take CBCTs in children unless there's an indication to do it. I also take CBCTs in adults when I do maxillary expansion to see if there's any asymmetry. I think you can diagnose asymmetries a lot better if you have a three-dimensional reconstruction of the images. And also, if there's, just to also be better able to manage potential complications that are along the way, but you cannot diagnose sleep disorder breathing on a CBCT.
I think that's really insightful for somebody who's practicing around this topic. Because actually, if you just read the literature, you would say actually anybody who's doing airway management is taking CBCTs. And I think maybe it's just an easy thing to quantify from a research perspective. But it's great to hear that actually that doesn't reflect clinical practice, because actually it seems to be quite variable in its predictability.
Maybe if I add one more thing.
Yes, please.
A lot of patients actually, they come to me because of their breathing problems, and they ask me if I will take a CBCT of them to see if there is a problem. And I actually tell them, to see if there's a problem, I would rather like to do a sleep test with you, because this will give us a lot more information than a static picture of your airway while you're standing upright and are awake.
Yeah.
So this is why I use a home sleep test, the WatchPad. Again, I'm not a sleep physician, so I'm not able to diagnose, but I think it's very interesting for me and the patient to have a look at what the metrics show.
Excellent. It's great to have had that question answered. Upper airway resistance syndrome. So I looked up for this particular podcast, and we're looking at the international classification. Upper airway resistance syndrome isn't there, but it gets described. So can you tell me a little bit more about what upper airway resistance syndrome is and where it fits into this sleep disorder breathing spectrum?
I don't want to speak out of my scope, so this is why I would like to highlight the topic from my clinical perspective. So again, a lot of patients don't have obstructive sleep apnea. If you send them to a sleep lab to do a polysomnography in the hospital, first of all, they're the outliers there, because I know because I've sent my patients there. So even the staff would say, "Oh, what are you doing here?" Because they're used to see old people, obese, who have obstructive sleep apnea.
Yeah.
And then I'm sending my young 30-year-old, lean as can be, fit person there, and what is she doing there? Okay, what I want to say is, with the WatchPad I'm using, it also captures the respiratory disturbance index. Of course, with the respiratory disturbance index, it's supposed to catch the RERAs, respiratory effort-related arousals. That means little micro arousals. I always explain to my patients, when the brain registers that there is increased effort for breathing, the brain wakes the body up so you can breathe better, because almost nobody is snoring during the day because their airway is stiff, muscles are tight, and breathing works. But during sleep, the physiology changes. So of course, those brain activity can only be diagnosed properly if you have electrodes on your forehead. However, the watchpad has a really nice technology. At least they claim that it's almost one-to-one accurate with polysomnography in the hospital. And I also double-checked it with my patients. It's really pretty accurate. So this metric is actually the most interesting one for me, the respiratory disturbance index, because most of our patients, they don't have obstructive sleep apnea. They're rather young, not obese, and they're not at the end of the spectrum.
That's really interesting. And it takes us away from this probably more simplistic approach that the airway is collapsing and being able to see that collapse happen, to now actually looking at, well, actually, it isn't collapsing, but it's disturbing them enough that it takes them into this semi-awake state, which then disturbs the quality of the sleep as we've discussed. And you mentioned about the respiratory disturbance index and its kind of relationship there, that it, as I understand, to brainwave disruption that occurs as part of that process, making it again probably a far more 3D picture as to what's actually taking place during sleep and taking place to the airway. I thought it was really interesting. Cheng spoke in 2014, who mentioned some patients with narrow airways volumetrically are still able to overcome those anatomical factors by dilating their airway during inspiration. And actually, it's not just a narrow airway, but as you mentioned, actually, it can be the arousal components that are resulting in some of those behavioral changes taking place. Now, in terms of preventing pediatric obstructive sleep apnea or sleep disorder breathing, if you have a patient that comes in and they're concerned, but actually from your diagnostic setup, you haven't been able to elicit anything, are there ways that you can, for a younger patient, think about ways of preventing them developing into this condition, or do you wait for the condition to emerge before you start to address it? Is there a preventive approach to this?
So obstructive sleep apnea in children, it most often involves enlarged tonsils and adenoids. I don't know if, probably, there is everything, but I would be very surprised to see a child with obstructive sleep apnea that doesn't have any syndrome, that does not have big tonsils, does not have adenoids. Okay, so the treatment for big tonsils and adenoids is removal under surgery, under general anesthesia. Who wants that? Nobody. Nobody takes general anesthesia for granted. So while what I can do, if I see, or let's start the other way. A pediatric patient who had enlarged adenoids for a very long time, and if it's severe enough that the patient cannot even breathe through the nose during the day, you can imagine what this maxilla will look like. It will not be wide and big. It will be a high-arched, narrow palate. So there's already an orthodontic indication to do expansion. Now, here's the thing. If the patient is also a skeletal class 2, this patient will not present with crossbite. And I think it's not enough to just look at the teeth. Oh, the teeth fit together. Well, there's a class 2. We will treat that later. When you can now help the patient breathe through the nose better. So I have treated patients, the adenoids have been removed twice. So it's twice a surgery under general anesthesia, and nobody saw the transverse deficient maxilla because there was a skeletal class 2, was no crossbite, and nobody helped this child breathe through the nose at night. So this child has been a mouth breather at night the whole time. And after the first weeks of expansion, he suddenly is able to breathe through his nose at night.
So this is a relative obstruction, isn't it? So either it's the tonsils that are obstructing the airway, or it's physically, it's a narrow maxilla which is there, and consequently that narrows the palate and the tonsils are there. So would you exchange having the tonsillectomy with expanding the maxilla if the patient wishes to not have general anesthetic? Do you see that being as a process to go forward, or is it always tonsillectomy and then having it? Which order does it go in? Least invasive first, the most invasive, or surgery first and then orthodontics?
I think this cannot be answered now because, if the tonsils are so big, even if you expand the maxilla, there will still probably be snoring or arousals during sleep. I think our job as orthodontists, and I like to call myself jaw orthopedist because this is the German word for my profession, it's our job to develop the jaws. And if we don't do our job, other people need to do it, but they can't do it as well. So the surgeon can widen the upper jaw, but not as well as we. They have to do big surgery. The ENT can make a little bit more space in the nasal cavity by straightening the septum, but he's working in a very restricted environment. We are the only ones who can meaningfully grow the upper jaw.
Okay. In terms of, if we switch to the medical tract, and then we describe the famous CHAT study, childhood adenotonsillectomy trial that took place over in Boston. They looked at patients going through 5 to 9, and some patients had surgery, some patients didn't have surgery, and they found actually overall there was around 46% from that study of patients who had spontaneous resolution to their obstructive sleep apnea. So this idea of watchful wait for these patients, as opposed to intervening both in terms of surgery or also in terms of orthodontics, means that they may have just grown out of it. Where do you stand in that respect? Should we watch and wait for these patients? Or should we, as per the previous question, be interventional and perhaps almost preventative to stop this condition getting any worse or even presenting itself? What should we do?
I consider myself as very conservative. So I always try the least invasive approach. When I do maxillary expansion, there's always an orthodontic indication to do it. That does not need to mean that there is a crossbite present. There can also be a transverse deficient maxilla in the absence of crossbite. So this is when I would widen the upper jaw and try to bring the lower jaw forward. So I would like to say that I'm not treating obstructive sleep apnea. This would be too much to say I'm treating obstructive sleep apnea because there are so many things that go into it. What I try to do is help my patients breathe better through the nose, and this is what I'm doing in coordination with an ear, nose, throat doctor. I want my patients to breathe through the nose, and there are different reasons why this can be difficult for them. Allergies, deviated septum, habit. So, for example, if the maxilla is well developed and I don't see an indication to expand, of course, I send them to the myofunctional therapy, do some exercises. If the maxilla is so small, high arch palate, it would be so nice for this patient if we expand the maxilla first and then do the myofunctional therapy exercises so the tongue actually fits there, and also look at the tongue tie. Is a tongue allowing to go up on the palate? So I'm very conservative. I work with ear, nose, throat doctors. I help patients breathe through the nose better if there's a structural deficiency of the upper jaw.
I think with mouth breathing, the AO recent paper that came out a few months ago described it's still very difficult to diagnose mouth breathing. There doesn't seem to be an established, if the patient presents with this or this quantity, they are a mouth breather. And also it's something which is developing. Lips are elongating at a slightly delayed rate to the skeletal growth. How do you make that call that this patient needs intervention for their mouth breathing? Or again, perhaps somewhat similar but adapted to the chat study, they're just going to grow into their facial structures and actually mouth breathing is going to stop?
It's always good to ask the mother. The mother knows. So I always ask the parents, do you see that your child is breathing through the mouth? And, if the child is laying like this in the bed with an overextended neck, this is a bad sign. This is not good for the spine. The parents know, they also have other children. They sleep completely different. They can tell if something's not quite okay. So also the children know if the mouth is dry or if the child has to wake up several times at night to drink a glass of water. Do you think this is how sleep is intended to be? I doubt it. I think if, our ancestors had to go to the well and drink a couple of nights, they would get eaten by the lion pretty soon. I don't think this is the normal way. It also leads to more cavities. Who wants cavities? So I think it's natural to breathe through the nose at night. I mean, it's like you can also eat through the nose, but it's not the right way.
So that's great. That's a great analogy. I want to ask you something a little bit more personal.
Mm-hmm.
You mentioned before that colleagues had advised you not to talk about this topic of airway in orthodontics because, quote, it could ruin your career. As somebody who likes to engage with colleagues, clearly you didn't listen to what they said, but I wanted to ask you from that perspective, have you felt any of this take place within your career in discussing this topic, in exploring this as an idea? And if so, what has happened?
I don't get a lot of pushback, to be honest. Also, if I do, I would welcome it. I think conversation is healthy. It helps me question, myself. Where do I believe something wrong? Where am I right? Where do I need to read the literature again or something like this? I just had once a situation where I gave a lecture where I talked about skeletal maxillary expansion and mentioned that it can help our patients breathe better through the nose. And then a very renowned orthodontist stood up after my talk and said, "You cannot tell your patient that they are going to breathe better through the nose." And I just think this is not very well supported by the literature. There is so much literature on rapid maxillary expansion and improved nasal breathing, resolution of nasal obstruction. So I disagree there, but I think disagreeing is healthy.
Yeah. I want to come onto this topic then of your treatment. So you mentioned you see yourself as a jaw orthopedist and taking that kind of German philosophy of function defining our treatment and giving stability. Now, one of the challenges, I suppose, of that philosophy, although we'll all agree to it to a degree, is what is the endpoint? What is the right size for the jaw? In terms of the transverse, there's a myriad of conflicting literature. What should it be, whether you CBCTs or not? Should there be a 5mm discrepancy, a 1mm discrepancy of the maxillomandible? In terms of the mandibular position, can we sustain that growth? Kevin O'Brien's systematic reviews and research would deny that and say you're accelerating growth rather than actually growing the mandible. All in all paints a picture that if we have function as our philosophy, what is the end goal, and is it actually going to stay with the patient long term? Are we temporarily accelerating growth, as Kevin O'Brien has stated?
I think it's completely wrong to think that there's an amount of millimeter that the jaw needs to have. We cannot decide, okay, this is the right size, and whoever is below has a problem, and whoever meets that goal is fine. We humans don't work like that. It's far too complex. We would like to have that as orthodontists. We love measurements. We love our S&A, S&B. It gives us confidence, gives us a way to assess things. Unfortunately, with breathing, especially with breathing, it doesn't work that way. I think doing a sleep study is a good way to look at what's breathing like during sleep, because we can't sit next to our patient while he sleeps. It's very individual. I just, my journey was, I was looking at teeth too much. I was trying to achieve ideal occlusion. And I was doing a lot of camouflage treatment, distalization in class 2. And I completely changed, not distalizing for the sake of achieving a class 1 anymore, because it's not about the class 1. It's about that the jaws and the teeth are functioning well and the patient is happy with their smile. And understanding how a lot of symptoms relate to underdeveloped jaws, I don't look away when a patient says they're clenching their teeth like crazy, or they're snoring or mouth breathing. It now all makes sense.
In terms of looking at expansion and improvement in terms of whether we look at the AHI index, we'll talk about an increase in the airway volume or reduction in airway resistance. One of the challenging things that we've got, there was a really great paper by Stacey Crow in 2017. Her paper showed that there was a positive improvement with rapid maxillary expansion in 70% of patients. Now, this paper has been interestingly quoted from both sides of the camp. Those who support it say, look, here we go, it works. Then there's the other side, who'll say, hold on. In 30% of the patients in the study, either things stayed the same or got worse in terms of repeat polysomnography, and specifically AHI index. If we have 30% as if we were to use different terminology, if 30% was a failure of our treatments, I think we'd all say that's not great, not good enough. Where do you stand in that respect? Because this same piece of literature is quoted by two different outlooks.
This is actually something that I tell my patients about, if they're mouth breathing and snore, or let's say they're just mouth breathing. And I tell them, we can expand your upper jaw, but it might even happen that you start snoring. Because I explain it like that. Imagine you have they have two sites of constriction, or let's say, you can all have all different variabilities, but this patient would have a very narrow maxilla. So there's a narrow passage up in the nose. So the patient is avoiding that by breathing through the mouth. But if we now fix the nasal cavity and the patient is finally able to breathe through the nose at night, there can still be a constriction behind the tongue because the lower jaw is so retrognatic. So this can create a negative pressure downstream because the air has to pass through a very narrow spot, and then they can even start snoring. So it's wrong to look at just one jaw. We have two jaws, and both are involved in breathing. The maxilla, as it relates to nasal breathing, and the tongue is attached to the lower jaw. So this here is the pharyngeal airway.
Yeah, I hear what you're saying, but that then relates the diagnosis, or the treatment at least, to the collapsibility of the airway and the physical component of what's being arranged there. But that won't relate then to patients, for example, etiology is going to be just low arousal in terms of their index. It's not going to relate patients in terms of their muscularity and the lack of muscular control. You mentioned frontomyofascial patients. Does that mean that actually there's a number of patients that this treatment is going to be, as at least the literature says, it's going to be unsuccessful treatment for them? How do you work out who is going to, or do you not find that those rates in your own patients?
I believe that with the nasal breathing, or well-functioning nasal breathing, is the foundation of healthy breathing. I think mouth breathing leads to a lot of problems. So I want to make an effort to make nasal breathing possible for my patient. I'm not saying that I'm doing the ENT's job. A lot of my patients, they already had several nasal surgeries. They had 2 septum corrections, they had turbinate reduction, they still can't breathe. Okay, and the maxilla is narrow, extremely narrow. So nobody built the nasal floor, and this is only what orthodontists can do. However, this might not be the only site of obstruction. So we cannot address a problem that is so multifactorial and just look at maxillary expansion, because there are also muscles involved. If the tonsils are big like that, there's still an obstruction to the airway.
Yeah, great. Extractions. Always debated. There was a great debate at the turn of the century, and it's never really gone away. Now, specifically related to sleep disorder breathing, do extractions contribute to sleep disorder breathing?
I don't think the literature supports this. I can imagine why. However, I think if there's so much crowding that orthodontists think extraction is a good idea, I bet that the jaw is not developed to its full potential. So it's a very low-hanging fruit often to just grow the jaw while it's still easy, while a child is still small and the sutures are not so ossified. However, just because someone has extractions doesn't mean they have sleep disorder breathing. I had my wisdom tooth extracted, but I think that if you had 4 premolars extracted plus 4 wisdom teeth because they also didn't fit, chances are that the jaws are really small.
So you're not seeing the extractions as necessarily the output of the sleep disorder breathing, but actually they are more indicating that there is a transverse deficiency. That's really interesting.
Maybe if I can say one more thing.
Yeah.
In my perspective, the goal of orthodontics is not occlusion, but jaw development. And this is what's reflected in a German word of orthodontics, jaw orthopedics.
Do you extract for your patients?
I extract a lot of wisdom teeth to distalize the lower jaw to then put it forward with surgery. This is the most common indication for extraction for me.
What's your opinion on the conventional extraction process in orthodontics, extracting 4 premolars?
I think it gives the patient a nice smile. This is what they care about in that age. Also at that age, usually they don't have a lot of problems. Maybe it's just mouth breathing. I believe that down the road, in many cases, it will become more than mouth breathing. It will become snoring and eventually sleep apnea. Also, you know, when you're 12, I don't think a lot of patients are in a psychological state to have orthodontic surgery. I hope this will change in the future. I think the surgeons are getting so much better. I've seen double jaw surgeries done in less than an hour with so low impact. So my hope is that surgery will be so low impact that more patients will embrace it and we have to do less camouflage treatment and can do more jaw development.
Okay. So you mentioned there how the focus really is getting the jaws into the right place, and the tooth extractions you've mentioned on some basis, but also you mentioned there that it could develop into that process of causing obstructive sleep apnea. We've got the classic study from Larson, 2015, which essentially showed in the adult population that extractions and non-extraction, 5,000 patients, and actually the rates of obstructive sleep apnea were the same between both groups. So it doesn't seem to be that long-term wise, at least according to that literature, extractions cause any harm to patients.
I don't think extractions cause any harm to patients. I don't think you can significantly make the jaws smaller by extracting the teeth. I just think it would be wrong to just look at teeth and occlusion and make this our final goal.
Skeletal expansion, what you were talking about today. I want to look at it from a different lens. I want to look at it from managing airways. How do you make a decision between using conventional rapid maxillary expansion for younger patients, and when do you decide to go into the skeletal side? Where does that difference lie in decision making?
So if it's an adult, it's always skeletal expansion. I wouldn't even think about using a tooth-borne expander. If it's a child, I have the conversation with the parents. I show them the 2 options and the pros and cons. We have the purely bone-borne expander, and we have the conventional Hyrax that is tooth-borne. The tooth-borne appliance has shown to have very small skeletal effects at the end of the treatment. The other option has only skeletal effects because I'm not even banded to the teeth. And I let them do the decision what they prefer.
Okay. I suppose the challenge is that in terms of skeletal expansion, it's not skeletal volume, and I appreciate what you're describing. In terms of the use of mini screws, we have a most recent study in the European Journal. The use of mini screws with skeletal expansion did significantly improve patients' AHI index. They used respiratory pulse tomography, which is debated as to how reliable that was. That was published just a few months ago. Now, prior to that, got a whole host of literature that would suggest that skeletal expansion relative to conventional RME may increase the volume, but doesn't really make any difference to the skeletal outcomes that take place between those two. That relates to Sarah Abu Arqoub's systematic review from back in 2021. Also looking at Farhan Bazangani's 5-year randomized controlled trial, which Bjorn Ludwig was involved with. We're seeing such a conflict here in terms of one piece of literature versus another, creating a very grey area in terms of confirming what you've described. How do you then navigate that?
So can I break it down for a second? So they say there's almost the same amount of skeletal changes using tooth-borne versus bone-borne.
Up to the age of 11, correct?
Yeah. Do you see the same in your practice?
Well, Claudia, I don't really answer questions, generally speak, on my own podcast, but I would say actually my use of skeletal expansion generally relates to patients who are much older. It's usually patients about the 16-year-old or older threshold. So from my perspective, I actually don't have the experience of younger patients.
For me, it doesn't make sense to use teeth as anchors for orthopedic movements. I think that was a solution for a time where we didn't have better tools. It's like if you're going home to your country riding a horse carriage. Yes, we did it for some time, and that was the best thing available. But today, you would take a plane.
Yeah.
Of course, I understand that mini screws require an anesthesia, a local anesthesia. To be honest, the children tolerate it really well, especially if the parents are relaxed. So I think you just get so much more out of one treatment. In the end of the day, I think that is the most minimal invasive treatment you could do. Because if you're using a tooth-borne expander, I don't get the same amount of expansion as I do with purely bone-borne expanders in children. I know this patient will have crowding later on still. He will need another round of expansion. Then he's older. So do we do tooth-borne expansion again, or do we then use skeletal expansion? So I believe that using mini screws whenever the patient and the parents are okay with that is the best option.
Okay. I think this is just probably just the reality is that sometimes there are differences in terms of what the research suggests and your patient cohorts that you're clinically treating.
May I just add one more thing?
Yeah.
You don't need a CBCT to do mini screw expansion in children. It's enough to have an intraoral scan and a ceph. So sorry, just wanted to add that because it would be really invasive, in my opinion, to do a CBCT in every child just to place 2 mini screws in the palate.
Bedwetting. So I was reading your blog on bedwetting and its potential solution when it comes to expansion. Can you explain how that process works?
I'm not a medical doctor. This is why I don't want to explain the depths of a bedwetting and all the things that can contribute. But I will say that during sleep, we're supposed to produce a hormone, the antidiuretic hormone, ADH, that tells our bladder, hey, it's night, we want to sleep, stop working. During the day, our bladder is working normal, and this is why we have to pee every couple of hours. So the production of this hormone can be disrupted if the sleep is very restless, and the sympathetic nervous system is activated, and the child is in some sort of stress. So a form of stress can be if you struggle to breathe, for example, snoring or subject to sleep apnea. So it's interesting that bedwetting is part of the Pediatric Sleep Questionnaire. where they ask about mouth breathing, they ask about snoring, restless sleep, ADH, and bedwetting. So I do the pediatric sleep questionnaire on all of my pediatric patients. And it's interesting to see that after expansion, those who made a yes on bedwetting, they say, since the appliance is in, there's no more bedwetting. And it takes off a huge burden. So I'm not treating children because I want to treat the bedwetting. I want to treat the mouth breathing and the restless sleep. That is, if there's a correlation between restless sleep and breathing.
Got it. That's really clear in terms of defining that actually it's a positive outcome of the process, but actually it's not the intent behind the treatment. And it's that low arousal threshold, which I think is now becoming, and rightfully so, having more light shone on it in terms of trying to work out what the disturbances are at nighttime in terms of breathing and the consequences that can take place. Claudia, thank you very much. I'd like to give you a small something.
Oh,
That's
thank
okay.
you. Wow.
This is something uninspiring, unoriginal, just like the host of this podcast. It's biscuits and tea.
Love it. Thank you so much.
My absolute pleasure. One last question. What advice would you give to the orthodontic community who are listening to this and to the dentists who also tune in?
You live in an amazing time. It's a great time to be an orthodontist. I would like to give the advice that there's more than teeth and occlusion to orthodontics.
Amazing. Thank you so much.
Thank you, Farooq.
And as always, please do subscribe and look forward to the next episode. Thank you, Claudia.
It was a pleasure, really. So you're so smart, really. Wow, I admire that.
Thank you so much. I'll click stop. That was wonderful.
Wow, nice.
I had